The question becomes, for this panel, what is evidence and can you derive it from expanded access? We will hear a rich discussion from 4 different viewpoints, just as we had a wonderful viewpoint from the last session. Here we will take a listen to a statistician, to a person from FDA who is part of the regulatory community, to someone who is actually in the business of helping patients get expanded access and delivering it to them. And I'm finally from a patient advocate who has a long history of, very much like what the prior group spoke of trying to get access available to people when they need it. Each of our speakers will speak for about 5 to 7 minutes. We will hear from, and then we will have questions from you and from us. We will hear from Hayley Belli, who is an assistant professor at NYU School of Medicine. We will hear from John Concato, who is from the FDA. We will hear from Rakesh Davda, who is with the company that gets access available, and from Pat Furlong, who is president and CEO of Parent Project Muscular Dystrophy. These are 4 very different perspectives, and I know that you will enjoy all of them. Their full bios are available, as is previously discussed, on the Isaac website. So let us start with a little tiny bit of background. The literature is a little bit clear, but certainly not complete, and you will learn a lot from this set of speakers. The literature says that expanded access evidence has been in use for regulatory decisions for some while. And some institutions, particularly those that are very much involved with cancer treatment, have benefited from a review, you might say, or a study of the expanded access cases within their institution. They were trying to see whether their policy was really beneficial to their patients. Now, from an ethical perspective, some believe that it's an ethical imperative to collect data. When the patients tested are treated with investigative medicines because you need to know about their own safety, you need to know about how data collection should be standardized. You need to know as well how regulatory agencies should develop usable methods to extract real-world data from expanded access programs so they can be used as evidence. So as you listen to these panelists, keep in mind what are the evidential standards that are important from each of their perspectives. And I'd like to start with Hayley. In the absence of perfect data, Hayley, a biostatistician whom we all love because they keep us out of trouble. In the absence of perfect data, do we routinely infer conclusions based on incomplete or potentially biased data? So do you think that's happening in the EAP realm? A perfect question for you, Hayley. Go ahead.
So just to repeat, so your question is just essentially, what do we do with these incomplete data sets that we have for in expanded access?
Right, and it might be biased.
Mm-hmm.
It's incomplete and potentially biased, right?
Mm-hmm. Yeah, so incomplete data is an issue really across the board, not just in expanded access. And so obviously we deal with this as statisticians frequently. So there are a lot of different methods that we can use with expanded access. I don't want to dive too into the statistical jargon, but things like propensity score matching for missing data itself, actually using imputation. But at the end of the day, we have to recognize that this is not clinical trial data. It is observational data collected in an expanded access context. So you can apply every statistical method in the book, every fancy cutting edge paper technique, but you don't have randomization. You don't have an active control arm, even if you try to have some kind of matched observational arm. So you just have to be really careful in looking at what is the population this was gathered from, how did these people ultimately access the product, what's our population, really just careful in how you interpret, these are the results we have given this population. So.
Thank you. Any further comments you'd like to make about how this setting is different from others?
Yeah, so in terms of difference, I mean, expanded access is meant for treatment, not research. And so
Right.
we have to keep that in mind that, we're here to try to treat patients, not necessarily do research. And so this line starts getting blurred, where if we're starting to collect a bunch of different outcomes with the goal of answering some research questions, then maybe this is a research study and we need to treat it as such. And so careful collection of outcomes, some kind of database management, all these things that, again, you'd see in a rigorously designed research study, which is not what we have here.
Thank you, Hayley. I'm sure that some members of our audience will have questions for you. I'd like to move now to John, who is going to share some slides about what the FDA is doing. And if you would go ahead, John.
Thanks, Barbara. And before starting, I just wanted to acknowledge the very moving experiences we heard from Anne and Sakun in the previous session. And I just want to emphasize, please understand that FDA is dedicated to reducing barriers and promoting awareness to make expanded access, when appropriate, accessible and user-friendly. With that said, though, I'll pivot to say good morning, good afternoon, good evening, and thanks for inviting me. I'll use my 5 minutes to provide a broad overview of FDA and real-world evidence, and then segue back to the topic of expanded access in particular. Next slide, please. As a reminder, real-world data, or I know I'll slip to say RWD sooner or later, are routinely collected from non-clinical trial sources such as electronic health records, medical claims, registries, patient-generated data, and others as shown on the left. On the right on this slide, real-world evidence, or RWE, is derived from the analysis of real-world data. But importantly, and sometimes this is overlooked, real-world evidence can include randomized trials, as well as externally controlled trials, observational studies. Next slide, please. This is a reminder that RWD and RWE are linked to the 21st Century Cures Act of 2016 in the US. The FDA Center for Drugs and the Center for Biologics have established a program to evaluate the potential use of real-world evidence to support a new indication for an approved drug or biologic, and to satisfy post-approval study requirements. Our 2018 real-world evidence framework and 4 real-world evidence guidance documents published last year provide stakeholders with FDA's current thinking on topics related to real-world data and regulatory considerations. And Sage will be putting some links in the chat to give you access to these documents if you're unaware of them. But I do want to add that importantly, the FDA standard for substantial evidence remains unchanged in ensuring that we honor our commitment to protect the public health. And also of note, as has been mentioned, FDA was using what we now call real-world data and real-world evidence to approve medical products actually before 21st Century Cures, and also before the current real-world terms became as commonplace as they currently are. Next slide, please. Expanding on that last point, this article titled Randomized Observational Interventional and Real World, What's in a Name, emphasizes that randomized trials versus observational studies, I should have put that in air quotes, is an oversimplified dichotomy when considering different study designs and causal inference. I don't want to get too technical, but it's a problem in that shorthand is great, but when shorthand generates confusion, it no longer continues to be okay. So we don't have time to go into details today, but the article also encourages greater clarity when sponsors and others describe study design and aspects of data collection, and that's also a link. Next slide, please. Turning our attention to how CDER and CBER evaluate real-world data and real-world evidence, basic yet very important considerations include, first, whether the data are fit for use in terms of the particular clinical context. Second, whether the study design provides adequate scientific evidence to answer the regulatory question. And third, last but not least, whether the study conduct meets regulatory requirements, with this last consideration, including requirements for study monitoring and for data collection, which are often very challenging when working with real world data, as you heard Hayley allude to. Next slide, please. As I've mentioned, FDA has been using real world data sources for many years, but here's a fairly recent drug approval as an example of how expanded access can be involved. The condition being addressed was a certain type of neuroendocrine tumor, and the drug lutetium or Lutathera was approved by FDA in 2018 based on results of a randomized trial and supported by an analysis of data that involved expanded access. Excerpts from the FDA review include the randomized trial providing primary support demonstrated statistically significant, robust, and clinically meaningful improvements in progression-free survival for patients receiving the drug. Reflecting the expanded access component in the second bullet at the bottom there, quote, support for the indication comes from a subset analysis of 360 patients for whom improvement in the overall response rates and response durations were both clinically meaningful and consistent with those from the randomized trial, close quote. The take-home point here is that the expanded access data were helpful, but they were not sufficient on their own for drug approval. Next slide, please. I'll close with a reminder of the regulatory requirements for all expanded access uses, including criteria for, as we've heard, the patient having a serious or immediately life-threatening disease or condition, no comparable or satisfactory alternative therapy being available to diagnose, monitor, or treat the disease or condition, the potential benefits to patients justifying the potential risks of treatment, which is one of our responsibilities as well, and then confidence that providing the medical product under expanded access will not interfere with clinical investigations that could support product approval, nor otherwise compromise potential development of the expanded access program itself. A lot to talk about, but with that, I'll say thank you for your attention, and I look forward to hearing the other speakers and to the panel discussion.
Thank you, John. And I know that we will return to your presentation with other questions. Hayley, I'm wondering if we might return to you for your comments. You answered my question, but you didn't have a chance to, to give a broader overview. So if you would like to take that time now.
Yeah, sure. So I guess it kind of ties into actually following now after Dr. Concato, who raised essentially this idea, the 21st Century Cures Act recommends the use of real world data to support regulatory decision making. So it's important to clarify that RCTs are still the gold standard for evidence, and they can't replace real world data. But real world data can certainly supplement RCTs, and that's the goal that I think we all want to get across here. And so the reason that we'd want to supplement RCTs with real world data is because sometimes RCTs are conducted in restricted populations. So that might be based on the participant inclusion and exclusion criteria. So we refer in this case, when we have this kind of data, as providing internal validity, which you can think of as basically as our truth within a study. But we're often interested in actually how generalizable these results are to a more diverse patient population. So the supplemental real world data can actually give us the sense of what truth is in the real world by providing us with external validity. So the question then becomes really, what types of real world data are best for supplementing RCTs, and what can we do with them? So I can think of essentially three broad categories, at least from a statistician perspective, I'm interested in. So we often think of safety data collection. So in terms of statistical considerations, we don't really have any limits here because safety outcomes often don't undergo any type of formal hypothesis testing, and just trying to observe what is happening out in the population is really important in terms of any types of adverse or severe adverse events. The second area I can think of is informing clinical trial design. So here, using these data to actually identify maybe biomarkers for a disease, determining characteristics upon which we might stratify when randomizing in an RCT, or even generating the hypotheses that we could use in a subsequent RCT. And then the third category that is often the one of most interest to people is efficacy. But obviously we have to be very careful here with real world data. So it's useful if we're in a rare disease space where maybe there are a few patients or clinical trials aren't feasible due to size or resource limitations, or for outcomes traditionally not collected in RCT. So especially from a patient perspective, things like quality of life measures, other patient reported outcomes. However, ideally, we would design a trial to include those, but I can understand where if you have many different primary or secondary outcomes, you just have to be careful with how many comparisons are being made. So this could be an excellent opportunity to collect these data. But why can't we use real world data for most efficacy outcomes? Well, it really kind of goes back to what I was saying at the start of our presentation, which there are these key statistical properties associated with RCTs that make them the gold standard. So things like randomization, control arms, clearly defined study endpoints, statistical power if we have a large sample size, or even bias control when collecting data and conducting the trial. So long story short, in the absence of all these characteristics, we have observational data, and it's harder to draw causal inference, even if applying statistical approaches, like I mentioned, like propensity score matching, missing data imputation, or covariate adjustment. And so with that, I'll pass it back to Barbara, and we can continue on. So
thank you, Hayley. That fleshes out from a statistical perspective part of what John was referring to. And we are collecting some wonderful questions in the chat, really regarding both of your perspectives. But let's move right along to Rakesh, who is the head of real world data and market access in Bionicle. And Rakesh, give us the word.
Thank you, Barbara. I'm going to attempt to share my screen. I'm more of a Teams player than with Zoom, but hopefully you can see my screen.
Yes, we can. Go right ahead,
Perfect.
Rakesh.
Thank you, Barbara. It's just the one slide from me. Apologies, I'm just having a couple of technical issues.
We saw your second slide.
Okay, Barbara, thank you. Apologies for the slight delay there. But firstly, thank you and good day, everyone. I think that's a safe greeting considering the various time zones we're across today. And also, I just wanted to echo the comments made around the previous speakers, such personal stories, and a real pleasure to be a part of these discussions today. I'd like to begin really picking up on a couple of comments made by Hayley. I think it's absolutely important to upfront appreciate the limitations of this type of data collection. In no way can we kind of try and replicate the RCTs. They're there, they're the gold standard, and our regulatory frameworks are developed to assess efficacy, safety, and quality based on those. So if we try and in any way replicate these trials through the data collection, through compassionate use, pre-approval access, then we're setting ourselves up to fail. And also Dr. Concato completely raises some very important considerations as well. For anyone, I think, involved in the design of this type of data collection or with a mere interest in data through compassionate use, I'd highly recommend the documents mentioned. But for me, the document mentioned around decision making, it's in draft guidance at the moment, and also Dr. Concato's article gave a good understanding of the broader global regulatory expectations when it comes to observational research. But I think a point for the discussions later, these guidance documents are fantastic and they give some great pointers on observational research. But I think it's fair to say that the guidance was initially developed and targeted towards additional indications and post-marketing studies, but I think there are so many learns we can take and start to apply to this area as well. There is a big temptation when it comes to this type of data collection when you set up a compassionate use program, expanded use, to collect data for the sake of it. You know, patients are on treatment, let's learn as much as possible from these patients. However, I think to successfully collect data in this space, it's absolutely vital to know what your end goal is. Putting that simply, there has to be a purpose for the data collection. There have to be data parameters in mind that we know of to try and achieve these outcomes. And the methodology based on the guidance mentioned has to be fit for purpose as well. Coming back to our experiences as a service provider in this space, it's great. There's equal appetite amongst small biotechs, you know, often with a single entity, all the way up to large pharma to collect this type of data. Being in the space we're in, you know, the therapy areas tend to be oncology, hematology, and rare disease. I think it's a rapidly evolving environment in terms of the landscape. Data collection in this space is not new. You know, we did some work looking at publications, you know, simple PubMed search, and you can go all the way back to the 90s and find numerous publications utilizing this type of data. But what's happened, I think, over the past 3 to 4 years has been a real change in the types of compassionate use routes available, and also the real world evidence frameworks. And that's together created a greater opportunity for this type of data collection with the limitations mentioned. But I think, again, emphasizing the points made earlier, and also based on the stories we heard earlier on as well, I think we must focus in and remember this is really around treatment provision. And, you know, it has to be designed, any data collection that comes on the back of this, to keep the low burden nature of it for physicians and their patients in mind. So what do sponsors approach us with when it comes to this type of data collection? It can broadly be put into 4 categories. Thinking about early insights, you can gain some great broad insights into the types of patients in terms of the treatments they received. We heard about you know, treatments for breast cancer earlier on, and you know, when it comes to international standards for giving treatments, prior treatments, often first, second, third line treatments are very different country to country. So we can have some real learnings when it comes to oncology about prior treatments that were given in this space. Also, we've had some really good experiences with adverse event management. You know, again, we've heard about the devastating side effects, you know, these treatments often have, especially when we don't fully know their safety profile. So we've been working with oncologists in this area to try and work out how they've prophylactively and treated adverse events. And that's helped to share these experiences to how we can keep patients on treatments for longer, which ultimately means benefits can be gained as well. So they're the kind of early insights. So what do we do with this data? So there's a real appetite to publish this type of data. I mentioned this has been happening since the early 90s. There's a real appetite in both scientific journals and also many pharmacoeconomic journals. So we think about ISPOR, for example, having real world evidence as the global trend and the area of interest, #1 in their global trends for the past 3 or 4 years. There's a lot, both from a pharmacoeconomic perspective and from a clinical perspective, we can gain from this. I think the big question comes back to regulatory dossiers. You know, we've heard many of the nuances and requirements when it comes to using this type of data for FDA submissions, and you know, the global perspective is very similar. We need to keep in mind this is compassionate use, and what we do gain from this type of data has to be shaped in a way we can collect it and to appreciate those limitations as well. And I think, although you know, we have frameworks for collecting this data, the EMA, for example, in their 2025 strategy, the European Medicines Agency has stated they want to utilize this data. There really does need to be further consideration towards design. It needs to be fit for purpose, and there's still a lot of work to be done in this area. I think an area that can really support and help is reimbursement. You we often, especially beyond the US, in Europe here, talk about this fourth hurdle. So we've got our quality, safety data and efficacy data through our trials, but it can take anywhere from 12 months to 3 years often to gain reimbursement, financial, whether that's through a health agency or an insurance company, to get the reimbursement for these treatments so they're commercially available, even post marketing authorization. So gaining insights on prior therapies and the cost effectiveness of this drug has been an area we've been able to collect really useful information. So in terms of, I've gone through why companies come to us. In terms of the key considerations for real world data, I just wanted to mention a couple of key areas we feel could be beneficial when collecting and designing this type of data collection. It's really important to have a clear regulatory strategy. I'm sure into the conversations we'll have some further insights into how different it is across the globe. Now in France, they've mandated this data collection through a couple of their routes. Also in the UK, we're currently going through a consultation process, NICER. So the Early Access to Medicine scheme, the EAM scheme we have, will require an element of data collection. It has to be fit for purpose. We've mentioned the methodology, protocols, statistical plans, platform design, how you're going to collect this data. It can't be done on an Excel spreadsheet. It has to be a fit for purpose data capture tool, all really important considerations. I've mentioned the minimization of burden. That's absolutely vital. We need to ensure that we prioritize the data points, the critical data points required. We do a thorough gap analysis and find out where the data will have the greatest impact. And for me, one of the most important aspects is stakeholder engagement. I think we talk about the importance of keeping patients and physicians in mind, but having steering committees, advocacy groups, having input into this type of data collection, making it more condition specific rather than the generic EQ5D data collection points we often look at in trials, can really have a positive impact on future access to these treatments. And with that, I'd like to pass back to Barbara, and I'm really looking forward to the wider discussions.
Thank you, Rakesh, and we very much appreciate your global experience with the issues that are important to patients. Hayley, there is a very good question in the chat. We will return to you after, and John, there are several for you. So please be prepared. But now I want to turn to Pat Furlong. We've already identified that she is the president and CEO of Parent Project Muscular Dystrophy. And we have the pleasure of hearing her today. I have heard her many times before, and I always come away absolutely thrilled with the perspective that she's able to bring. So Pat, please go ahead. And there are questions in the chat for you too. So after you're done with your presentation, please take a look at them. Pat, you're muted. You have to unmute yourself.
Thank you. The difficulty of Zoom these days to figure out when you're on and when you're off. So thank you very much, Barbara, for allowing me to participate in this really informative discussion. And I so appreciate Rakesh and Hayley and Dr. Concato's comments. Expanded access programs are essential in rare diseases, and I'd like to make the story about rare disease so that we can get some context to some of the points that have been discussed here. I think it's really important to understand when we look at rare diseases, we don't have progression-free survival. We don't have tumor size. We have a very difficult situation in terms of rare diseases. And to set the stage, I'd like to talk about Duchenne muscular dystrophy. Duchenne is an inherited X-linked recessive pattern characterized by muscle degeneration and weakness due to the alterations in the structural protein called dystrophin. Without dystrophin, muscle cells are unable to survive. This leads to muscle wasting that progresses over time. My mother used to say when my sons were diagnosed, you can't die well over 20 years because from the date of their diagnosis, they would progress and lose all muscle function over those next 20 years. So can you imagine in a clinical trial trying to figure out what is the primary outcome measure here? Typically, these individuals stop walking in their early teens, and it's highly variable. They're unable to lift their hands to their mouth in their mid-teens, again, highly variable, and they need ventilatory support in that same time frame. The mean age of death is the third decade. So the Cures Act was signed into law on December 13th, 2016. We were thrilled. The legislation designed to accelerate medical product development and bring these new innovations and advances to the patients who need them faster, more efficiently. But time is the commodity for people living with diseases that result in progressive loss of function, whether it's skeletal muscle or cognitive or otherwise. And the law builds on FDA's interest to work to incorporate the perspective of patients in the development of drugs. And clinical trials certainly are the gold standard. Clinical trials in rare diseases such as Duchenne include only subsets of the population, small groups of individuals who are walking, for example, utilizing outcome measures that are not sufficiently sensitive and do not appropriately reflect what happens in the environment, such as school or home. In addition, we need to keep in mind that the subjects are children, and forgive me, in our case, they're boys who are very distractible and very subject to these outcome measures, depending on the mood, the shoes they're wearing, the parent that brought them, the travel they had, and many other reasons that may reflect and negatively impact their participation in the clinical trial and the outcome measures. Furthermore, in Duchenne, where progression is slow, outcome measures and PRO instruments are borrowed from other diseases, and they fail to understand and describe the nuances of progression, nor do they reflect the priorities of patients and families. This is where real-world data is critical and supportive and necessary to understand the impact of any given intervention. For example, in progressive diseases such as Duchenne, boys will make accommodations to facilitate certain activities. For example, early on in the disease, they can alternate feet going up the steps. But as the disease progresses, they will stop alternating feet. They will use handrails, one at first, then two. Then they will turn toward the handrail to pull themselves up the steps. These nuances are never, ever captured in an outcome measure. This type of data is often not captured appropriately, and we know that boys with Duchenne never lose those accommodations once they're established. And for the payers, as Rakesh mentioned, look at the one-time score over time in a clinical trial and make decisions without the support of, or sometimes any evidence in other populations. Making decisions around access translates into those who do not fit the criteria, often are unable to access the interventions, and increases the burden on families to figure out how to navigate that path. And again, time is the commodity. Years of navigation, years of trying to get access to a given therapy means loss of function by definition. And finally, clinics enter data in all different ways in the AHR. Because data input is inconsistent, it's often impossible to make sense of the data entered into the AHR. For example, defining loss of ambulation in one clinic was used as observation of a full-time wheelchair, or the parents suggesting that the child stopped walking, or the measure of inability to do a 10-meter walk. Real-world evidence and real-world data is essential to provide supportive evidence to clinical trial progress and to reflect the priorities of patients and families and provide payers substantial evidence for access to all who have the potential to get benefit from a given intervention. If we don't look carefully at this type of real-world data that we are collecting and make adjustments, it's not going to translate into real-world evidence. And that's why I think we have to think through how do we conduct clinical trials in rare disease populations, especially when they're involving children who don't understand the rigor needed and are subject to variable influences as they conduct these trials. So with that, I'm going to turn it back over to you. I think this is such an important discussion because I think expanded access programs are necessary and essential so that we understand both the benefit and risk in these populations and across them. Thanks, Barbara, back to you.
And thanks, Pat. You're terrific each time I hear you. So,
very kind.
And we will return to the first terrific speaker, which is Hayley. There is a question in the chat. If you could address that, please, Hayley.
Yeah, so there's a question in the chat that essentially to encapsulate the theme is kind of asking about why is there this reluctance to data dive into some of this ad hoc evidence, and why aren't we prioritizing essentially looking at some of the evidence in these rare disease spaces, which is a very valid question. The issue at hand is this question of how do we know something is evidence, which is really the theme of this panel here. And so first I'm going to talk about large scale clinical trials, and then I'll extrapolate to the issues then that raise here with say a rare disease, which is the opposite. So in a large scale clinical trial, we establish a primary outcome, some secondary outcomes, and everything else is exploratory. What that means is essentially we have to pick before the actually doing the analysis, basically what we care about most, And the reason is because if we just care about everything equally and we have hundreds to thousands of hypotheses that we're testing, we might find positive results just by chance. So it might actually not really be an effect, but just the fact that we did so many tests, we might find some positive results. So what happens, as you can imagine, in a rare disease space, the study would actually have to be designed around that rare disease, because often what happens, and this is the unfortunate reality, that we have studies around some other larger disease space, and then suddenly these rare diseases pop into the information picture, but the actual primary and secondary hypotheses weren't designed for studying that. And then again, as I said at the start, in expanded access, again, this is intended for research or intended for treatment, not research. So what this means is for rare diseases, there has to be a specific study actually looking at this where we set forth a primary and secondary efficacy hypothesis to test. But it's also tricky because they're rare diseases. You have small sample sizes. So the smaller the sample sizes, the larger your error bounds are going to be. So unless the effectiveness of the treatment for the rare disease is super large, you're going to have these really huge confidence bounds, and it's really tough to see whether or not would be then effective or efficacious in, say, another similar population. So basically, it's just the nature of rare diseases that makes it really hard to test for efficacy. So I think really what the answer to this is, it shouldn't be neglected. It shouldn't just be like, this is hard. The answer should be, we need studies that actually are research focused, targeting rare diseases that actually have set forth primary hypotheses to test efficacy. And so I'll scan real quick and make sure
that you answered the question.
So,
and if she didn't, you can, the questioner can put it back in the chat again. John, thank you, Hayley. John, there are multiple questions for you. You probably had a chance to take a look in the chat, and if you could address some of those.
Yeah, very excellent questions, but I do want to take just a couple minutes. I think this is a wonderful conversation, but all of these questions are about specific aspects that are interrelated, and I think we would benefit from sort of backing up and thinking of the big picture. I think Hayley said it. I mean, fundamentally, the difference between research and treatment, it's a continuum with a bit of overlap in the middle, but it's not, they're not completely separate. So it's not fault, quote unquote, if you know, as we heard with the very moving stories, I mean, the goal there was to get treatment to the patient. And there's so much else going on. It doesn't mean we can't look at the data, but we have to be realistic that these data are not, and it's not as if we're just saying, oh, we can't accept anything other than trials. On the contrary, not only do we have guidances, we have demonstration projects that are seeking to improve the quality of real world data, sort of raise the tide. We have approvals, including one in July of last year that was entirely based on quote unquote observational data. It was from a registry. It was for an orphan condition in the sense of a drug for preventing rejection of lung transplant for various reasons. That indication had never been approved. So I think it's fair to say that FDA is moving forward in this regard. I think that there's another underappreciated aspect of the situation. It has been alluded to, but randomization is wonderful. But even small trials, as Hayley, I'm sure I trust will agree with me, if the larger the trial, the more you have that balance, and therefore confounding and bias are minimized. But with small trials, the balance doesn't always work out, and sometimes you're left wondering whether, if the patients who got the treatment had less severe prognostic factors, perhaps they did better for that reason. I don't want to go down into very technical arguments, but I do want to say that the trial infrastructure is sometimes underappreciated. That research protocol that gets high quality data that we could be comfortable with. It's not that FDA doesn't want to help, of course we do, but there are studies that are done that just don't have adequate data in terms of the data quality or the monitoring involved. We're not looking for perfection, but we are looking for data that we can have confidence to honor our mission to protect the public health. We respect the patient's perspective, but our responsibility includes safety. And the last thing we would want to do is have a situation where patients are harmed. Now, having said that, a study was done, I don't remember what year, before I joined FDA, and that was just a couple of years ago myself. But it's almost unheard of where any adverse event information from expanded access has prevented FDA from approving a drug. So if we could make better use of the existing pathways, including expanded access, I think we'd be in much better shape. And I know I'm not answering all questions yet, but I do think I haven't had a chance to point out the extensive resources that are available. I think part of what was so moving about the stories was how much effort it took to become more familiar with expanded access. But what Sage, thank you again, you put different links in the chat. Our FDA website alone provides resources, including videos, a recent webinar, specific guides for patients, providers, and sponsors. One important one to mention is the Reagan-Udall Foundation for FDA's Expanded Access Navigator for single patient INDs. I don't know if that was a use or even in existence, but it provides information to help patients, caregivers, physicians in finding a product. And as we heard earlier, we need everyone involved here to be more aware. Hopefully most clinicians would want to be as helpful as possible, but if they're unaware, explain their hesitation. Importantly, the Foundation's website also includes a tool that was launched in late 2020 called Expanded Access e-Request. And so in this era of technology, it's nice to have an app. It walks users, primarily treating physicians, through the process involved. So again, I mentioned in my comments, we want to make this more user-friendly. We operate under the regulations, but there's room in these regulations to make expanded access as good as it can be. And another project, since we've heard about cancer, is Project Facilitate for oncology products. That should be very well known. So sessions like this today can help to promote awareness. And actually, it should be self-evident, but it's not listed in the chat. I should mention the NYU Langone working group on compassionate use, where you all have put together research papers, fact sheets, webinars, FAQs, and the like. So let me pause there. I will say one question that I saw, I will just point out that we are working very hard and we are very pleased to show our progress in terms of honoring 21st century cures, not just on paper, but in practice. And having said that, I will not comment on behalf of FDA in terms of Cures 2.0. Nothing should be read into that as much as we are working hard and have more guidances to generate, et cetera. And we do think that we're in a good position to make real world evidence be as helpful as it can be. Thank you.
And thank you, John. And just one follow-up question. Are there other additional parts of 21st century cures that remain to be rolled out that you're working on?
In terms of the real world evidence domain, we have honored our commitments. I will say that, let me be clear, Congress has not reauthorized the Prescription Drug User Fee Act, but what pops into mind in terms of FDA's continuing efforts in this space is that it is public, is that the commitment letter for prescription drugs included a segment on real world data, real world evidence called Advancing Real World Evidence Program. And that is another effort, should it be reauthorized by Congress to start in the next fiscal year, where FDA would be in a position to further promote real world evidence. But I also want to emphasize, yes, we've heard about the wonders of randomization, totally agree, but I mentioned the research infrastructure. And ultimately, I'm comfortable in saying that when I approach wearing my hat, say, convening the real world evidence subcommittee that looks at proposals involving real world evidence, one can be agnostic to study design and still honor what we know about randomized trials and observational studies. That is, we do not say up front, oh my goodness, this is observational, therefore we're not going to look at it. Rather, and we're also not just putting this through a robotic algorithm to say, oh, it doesn't pass the quality. We need to, as professionals, as scientists, as epidemiologists, biostatisticians, clinical reviewers, et cetera, regulatory staff, the confidence that the benefit risk profile to approve a drug is satisfactory. And we are doing everything we can before drug approval with these different pathways to make the drug available in situations where, again, it makes sense. And it's not just reading the sort of black and white words on the page, but rather putting that into practice, try to promote the public health and respect the individual situations that everyone is in under sometimes, extremely dire circumstances.
Thank you, John. And notice that in the chat, one of our attendees says to the FDA, please give us a project facilitate for more than just oncology.
Well, but that's, I'm sorry, we have what I described for the Reagan-Udall Foundation should be, we could sort of put them side by side and compare notes, but please appreciate the progress that has been made and the opportunities that are there. I'm looking at you, Barb, and talking about, not have seen that last comment, but depending on the details, I'll go offline and be prepared to give a specific answer.
Thank you, John. And Rakesh, there were some questions for you as well in the chat, and I have some questions for you too, but you could go right ahead.
Thank you. I'll just pick up on one of the comments made regarding the collection of data. I think we have to appreciate the limitations, and some of the questions coming in linked to this. But I think, John, in your paper, and you can correct me if I'm quoting it wrong here, but you mention around the constructs of designing this type of data collection and looking at, prospective, retrospective, primary data sources, secondary data sources. And I think this answers a couple of the questions. And, there's some great points about this type of data has been used and will be used for approvals down the line. But, I think there are very few where it's being used alone for this type of approval for the FDA, right. But where it does work is as a supporting role with the wider RCT evidence. But, I think a key point here is, if we look, because there's some mentions around outside of the US and starting to discuss that, these decisions around funding have been made for 5 or 6 years now in the UK and France. And what we've seen now in France just very recently is the mandated collection of data. So if you're going to set up this type of program in France, you're going to have to collect data with that approval of the provision of the treatment. And what this then means is it's now moved over where previously it sat with the ANSM, the regulator in France, for the provision of these requests. It now sits with HAS, which are the provider of funding for these treatments, making the treatment decisions. And so I think there's been a real shift in Europe that we're not only looking at this as potentially some additional data collection, but almost a must now moving forward. To, if we're going to provide treatment for these patients, we need to start to think about how can we utilize this data. As long as the focus remains on treatment, how can we utilize this data? And it's finding the areas where this data can have the greatest impact. But John, I just wanted to comment, because I read your paper quite recently, and I think you made some fantastic points around that. Rather than calling it real world data, do we call this by the constructs? I think that's really important.
On behalf of myself and my co-authors, thanks. And I'll just respond. I think this also brings up another point. First, the idiom like walk before we run. By all means, we should try to capture data better. And it's not as if FDA is sitting back saying, oh my goodness, we'll never accept this. Rather, it's a fit for purpose on a case-by-case basis. We want to adhere to our regulations, not because they're just regulations on the printed page, but they have served extremely well over the decades to provide safe and effective medications. I know we could always be criticized for being too fast, or if something goes wrong, too slow if it's not approved. We have Congress helping by passing regulation, which then becomes, passing statutes, which become regulations, and those have to be quote unquote socialized. But one thing that Pat said struck me among many excellent points, Pat, but the idea of endpoints, I mean, that's not limited to real world data, real world evidence. FDA is working hard to improve endpoints, and we could put them in clinical trials. So there isn't, again, this dichotomy of randomized trials or observational studies. But I'm sorry, Rakesh, your main question for me, if you could repeat it. I just had those other items on my mind.
No. Thank you. So it was related to that. It was around observational research on the constructs, rather than looking at data as real world data. I think often we look at endpoints and we say, right, we need to have this endpoint and that and it has to be designed in this way. But I think your paper makes a really nice point around not only the constructs of the data, but then I think it was called the prognostic determination as well. And if there are areas where we really need to focus in on, it's those where we can't measure these in trials, and if there's nothing to almost, you know, I don't want to say nothing to lose, but, you know, collecting this data can potentially have such a big impact further down the line, should we make it mandatory in certain collections?
No, that's exactly right. And then the prognostic or causal determinism, I think we have to keep clear again. If we're talking about like a single patient IND, we're in a different space. If we're talking about, say, expanded access coming potentially from a larger population, but that's part of the problem. We love it, quote unquote, when we hear that a tumor regresses, or when a rare disease with a long chronic course, the patient gets better or at least doesn't get worse. But it's not that we are just stuck in the sense of we always need a pristine randomized controlled trial. How can we be confident that the evidence is not due to the variability in different patients? And this is what Hayley was emphasizing earlier. So we are trying to, if we're all rowing in the same direction, we'll make progress that we'll look back and hopefully be impressed with how much progress we've made. But we are, again, working hard, both in terms of making the expanded access opportunity, which, as we heard, I think at 9 a.m. or so, right? The outcome cannot always be, unfortunately, as good as we want it to be. But what we have to work hard on is making the opportunity be as user-friendly, as painless as it can. But yes, Rakesh, in terms of observational data, we are, excuse me, in terms of, let me practice what I preach. In terms of interventional study design, AKA observational studies, if we could do more work to improve the data quality and the aspects of data provenance, et cetera, then we'd be in better shape. But it's not going to happen overnight. And I think we just have to work hard at it and work continuously at it.
Thank you. And Rakesh, I have two other questions for you. There may be more in the chat if you will look, but one of mine is, should we remunerate providers for data collection in non-trial pre-approval access? And a second one is, in your experience, are payers reliant on or interested in expanded access for their decisions?
Absolutely. Thank you, Barbara. I think two very good questions and very related questions. So the remuneration question, if you asked me the same question 12 months ago, I would have definitely said no, because this type of data collection needs to remain independent. And if you pay for this type of data collection, could we potentially be incentivizing you know, the collection of data? So I think there's a big discussion to be had there. But for me, the tide is changing. I mentioned France as an example where they're mandating this type of data collection. We spoke to an affiliate on Friday, and it's the first I'd heard of it, but they're putting in a framework to make payments a requirement as well to healthcare professionals for collecting this type of data. And it'll be the sponsor that makes this payment for the collection of data. So I think the tide is changing in that direction. And to the points we've made around, you know, if we're going to look at the methodology and the quality, we want to move this type of data collection to be fit for purpose, to meet the requirements of the FDA. You know, we're setting up programs now where we've got statistical plans, data management plans, you know, we've got these amazing platforms that we can have medical coding in and create SDTM data standards that the FDA and other regulators require. We're looking at so many different elements, and ultimately we're trying to deliver data that's, you know, closing that gap potentially between what we create in this space versus an RCT, which will never catch, but I think we can reduce that gap. So if we're asking these improvements in quality, that's it's an increase in time for the physician. They may want to give that data collection, that input, into someone else in their hospital. So it could be a data manager, a hospital, a research nurse, etc. And by remunerating, I strongly believe we could potentially allow the quality to also follow. So my belief is, yes, I think we should be now giving an option of remuneration. And to your second point around, you know, is this data being used? Absolutely, absolutely. You know, speaking about European examples, the UK, France, in the last 6 months have developed their guidance on collecting data in this space to support their reimbursement decisions. Frequently they collect what's known as the EQ5D. You'll be aware of a generic quality of life questionnaire. They base it on the quality and the quantity of life, make an adjustment of the cost per quality, they call it. It's so generic in what it collects, and they really want to open it to condition-specific areas. But to make comparisons between different therapy areas, they need to keep this quality of life collection generic. But what we can do in this space is often, because it is so condition specific, start to look at better ways of collecting these outcomes. And I know, Pat, you've touched on video evidence. I think that's a fantastic way to, and we've had approvals in the UK that have used video evidence to gain reimbursement to drugs. So why not explore and use this data moving forward?
Thank you. Very rich discussion. And Pat, there are some questions in the chat for you as well. But I wanted to ask one as well. How often are patient groups involved in planning data collection for expanded access programs? But feel free to respond to any of the questions in the chat.
Sure. So we have been involved in most data collection, and certainly in outcomes development that are specific and perhaps more sensitive to understand the progression of Duchenne. The North Star assessment, which is typically used in these trials, is a global measure, for instance, of 17 measures. And the FDA is asking, if you have a 2-point difference, what does it mean? Which made us think, it's benefit, of course, if these children are improving in some way, that increases that score. But that's why the group of patients and communities looked at video capture. So because we think it's a much more sensitive way to understand how this child is accommodating various activities of daily living and as supportive evidence. So I think that having the advocacy group directly involved in real world evidence collection is important, as well as the clinicians, so that it's consistently entered. Because as I just gave the example of the condition of being non-ambulatory or unable to walk can be measured by unable to do 10 meters or a variety of other ways. And if that's inconsistent in the electronic medical record, then we really don't have a sense of what are we looking at and what kind of data are we providing to both the FDA as supportive evidence as well as the payers, so that children and across the spectrum of this disease can have access. So I think this is a place where advocacy groups can really be instrumental in developing these outcomes that are supportive data because of the real life experience of these patients and their families.
Thank you very much. And we have someone in the chat said that Project Facilitate is listening to the webinar. So glad you think the program is beneficial. So we're glad to hear that. We're
Absolutely.
very pleased about that. I just have, do any of you have further comments?
Yeah,
John, go ahead.
I do have one thought. It occurred to me earlier on when we were talking about, randomized trials, just to point out that hopefully this is not sufficient on its own, but as we see decentralized clinical trials become more and more feasible, a combination of technology and regulatory agencies working hard to see how we would intake that data and evaluate it, et cetera. But there should be a future state where patients have more access to clinical trials, even when they don't live nearby a trial site, et cetera. So again, It's not panacea, but we have to appreciate that we don't want to lose the opportunity of clinical trials. And again, the expanded access regulations talk about not being eligible, and we heard the stories about how you run out of options. So all of these things have to fit together to make as many opportunity as possible for patients in very difficult situations. And one other comment in the chat box, I think we do approach study design agnostically. We also approach each disease with the intent of doing everything we can. Oncology cancer is obviously horrible, but to the extent that there are some endpoints, some outcomes that are more amenable to be evaluated, say compared to some rare diseases, it's just part of what's baked in. So there is no quote unquote, I forgot the word in the comment that have to go back. It's not as if there's an imbalance, or if there is, it's not because of FDA's position. It's more inherent in the clinical context, or inequity, I think was the word that was used. Thank you.
Thank you. I have one other question for all of you. What developments need to occur with electronic medical records to facilitate real-world evidence? Now, I'm a nurse, so I will tell you that one of the things that needs to happen in medical records, and don't call them medical, call them electronic healthcare records, is that they need to systematize and document all the care. And one of the things that is still on the outside pretty much is the systemizing and with diagnostic codes and treatment codes for nursing care. So that's one thing that could occur. I've also heard from people who tried to harvest data from electronic medical records that there are not standard definitions, that you can't get the death certificate till 2 years after someone dies, that sometimes you have to go in depth into the nursing record because it's not systematized according to diagnosis and treatment from nursing to get the data you need. I mean, so where are we going to go with electronic medical records?
Yeah, I'll start if I'm, oh, I'm sorry, that was the Hayley. Go ahead.
Let Hayley give it a whirl
No,
first.
I'm sorry,
And
go
then
ahead. Yeah.
John.
Yeah, so so actually my primary area of research is actually in pragmatic clinical trials, specifically those that collect outcomes in the EHR. And so for those who aren't sure what pragmatic clinical trials are, you can almost think of it as a hybrid between real world data and randomized explanatory clinical trial. And so as a statistician, the number one things that I observe that I find, so keep this in mind, this is my area of research and I do a lot of studies that are embedded in the EHR. But the issue is always, there are both errors just by human error, clinicians, staff, people are moving fast. But then there are sometimes errors that I hate to use the word on purpose, but ordering a specific test, but labeling it as something because insurance will cover it if it's labeled in that form. So you don't necessarily know if the medical record is actually accurate and if that's necessarily what the person received. It can be very problematic that a lot of patient characteristics are often omitted. And so especially in terms of things like health disparities, things like race, ethnicity, gender identity, usually gender identity is just listed as binary. It's these things that can be very challenging to reach certain populations. And so basically we need to somehow improve the accuracy. We need methods to kind of test when it's just not feasible. You're seeing extraneous values that just does not make sense. How to kind of detect these things, because unfortunately at the core is we can do different statistical methods, but there's biases and you can't necessarily correct some of these biases even with fancy tests. So my take on it is here I've said all these negative things. I think the electronic health record is an amazing thing. I think we have this at our tool. We have data. We can observe real world data from this. But with anything, we have to just ask this question that I think has been the theme of this panel, which is data fit for purpose. So whether it's an RCT, whether it's expanded access, whether it's an observational study, it's just like, why was this data collected? What was it used for? What was the population was intended to target? And so in any study, regardless, I think we just have to sit down, look at it and just ask these things. Who's the population it's in? Why was it collected? And just brainstorm. What are potential biases that may have arisen in this data that we should note as potential limitations, whether or not they actually exist, but perhaps could be there. So,
and frequently, Pat,
Barbara, I'd love to build on Hayley's comment.
Yes,
first of all, I think the electronic medical record is terrific, really terrific. But I think we need to have a doc flow sheet that says, what is it that we're collecting consistently across? What is it? And what are those definitions associated with what we're collecting so that it isn't all over the map or very difficult to interpret? The other point is sharing data. We PPMD has been working on certifying Duchenne centers in the United States and outside, and using a doc flow sheet of data collection. But I have to say, people are unwilling to share data across. It's their data. They're going to use their data to publish on their data when they can, when they have time. And all the time is patients' commodity, right? So we can't let data sit in silos or be unable to be integrated into a patient-reported outcome. For instance, many advocacy organizations, we are one of them, that have the ability to integrate with the patient's consent, the electronic medical record, and that doc flow sheet into a patient-reported outcome. So we really have a very good picture of what this patient looks like. So I will say doc flow sheets, data dictionaries, the integrated data and sharing data is crucial if we're going to understand what this patient looks like at this moment, what therapies are beneficial and useful. And again, last point is, what data do you need to collect and what is nice to collect? Because sometimes these patients, the amount of data that collected is non-essential and doesn't give you a good picture. So what can we collect that's meaningful, that's fit for purpose, that tells us what's going to be useful or what has been helpful in this particular patient? Otherwise, I think we're not really serving the patients well.
And plan it with patients.
Exactly. Oh, Barbara, yes, of course.
I knew that's what you were going to say.
Yeah.
And it's important. Right. So Rakesh and John, some last comments. We're running very low on time, and Andrew soon will cut us off. So,
if I could, first
please,
I'll just
John.
mention FDA's activities under the umbrella of patient-focused drug development are aligned with what we've just been talking about here, to make sure that not just because it's the patient perspective, which is all important, but it's also good medicine, good methodology, good science, right? To have meaningful outcomes. I'm happy if my lab value improves, but I'm even happier if my function improves, so to speak. But I also wanted to focus on the electronic health records and just mention a little bit more about our so-called EHR and claims guidance. We talked about both of those data sources. It's really an attempt on our part to help stakeholders understand our current thinking for, like, how do they validate? It's not because we're just being difficult, but obviously everyone on this call appreciates, as has been said, just because something's entered in the medical record doesn't mean that it's ready and reliable to be used. We talk about clinical relevance to the question at hand. So we don't sort of say that just because a data point is good for, if it's an extraneous variable, it's different than if it's an outcome. The second is the reliability. But I also want to link it to our demonstration projects. What we're trying to do, and this occurs in cancer and non-cancer spaces, is have the information that we would collect in a trial be almost a pop-up on a screen. Like, why wouldn't, as has been said, why wouldn't clinicians want research-grade data to treat their patients? So I know it's a heavy lift, it's a long haul, but all of this is enabled by the so-called era of big data, which is really underlying all of this real-world data, real-world evidence discussion that we're having. The ability, it used to be we had to look at paper records, and it's just unmanageable. Now we have the converse problem of there's so much information, it's separating so-called wheat from chaff, et cetera. But I do think that if folks haven't looked at it, more so on the sponsor side, in terms of, but patient advocacy groups as well can benefit from understanding the thinking of FDA. We want to help, but we also want to make sure that what we're doing is rigorous. Yes, if patients are in dire need, anything is better than nothing, but anything must at least pass a basic screen of being safe and potentially effective, as opposed to just false hope in that regard. Thank you.
Thank you, John. Any final words, Rakesh? We're almost out of time.
Thank you, Barbara. Yeah, just to really echo the comments, I think with this type of data collection, we have to note the limitations, but I think what we're talking about today and some of the, I suppose, differences with this type of compassionate use pre-approval access data collection are that if you start early enough in your planning, we're talking often we start 3 to 4 months prior to the program going live for treatment provision, we can build in some of those gaps. We can prepare for those gaps. We can almost have, because it turns into a mix of a prospective and retrospective data collection. And so you can identify where those gaps are going to be in the electronic health records down the line and complement it with a well-designed CRF. and source data verification at the back end of it as well. And this is, I think, the key driver in Europe, giving a bit of a global taste on it. You know, in France and the UK, they're looking to start this data collection earlier to fill those gaps. So at the back end, we can have data that you can make these types of decisions on. Not going to be RCT level data, but as we've discussed today, I think really nicely in rare diseases, where we're talking single arm trials, where we're talking smaller populations, it can really make a big, significant difference to future access.
Thank you so much. Any final comments before Andrew cuts us off?
Well, yeah, just the last comment that was put into the chat box.
Yes.
I hope my invoking of the phrase false hope wasn't misunderstood. I totally agree that, and this is what expanded access is set up to do. If there's an existing trial that shows promise, we should make that drug available via expanded access. I think, you know, where it gets very complicated is if how you sort of define like subsets of subsets and where there's a credible, if this actually, I would say if the signal is promising for the overall trial, that's where expanded access is ready to be initiated. So I think we are at risk here of being misinterpreted or misquoted even, but I think we're all rowing in the same direction to try to move this field forward and help patients. Thank you.
Thank you so much to the panel. And I think we've covered a lot of ground and given some great suggestions and also examples about how the field is moving forward. So maybe for another CUPA conference. Over to you, Andrew.